And one question here, but yeah.
I visited Haiti last year and taking students there this year.
Right.
And I was able to visit some students at the Catholic University in Port-au-Prince.
Mm-hmm.
And one of the things we were in our conversation with each other, you know, like what are they majoring in and what do they hope to do? And a lot of them spoke of wanting to leave Haiti, wanting to come to the States, wanting to get a better life. And on one hand, you can understand that, but on the other hand, when you think about Haiti and how the brain drain has really affected the possibilities for transforming the poverty and the terrible condition that the country is in, I mean, I understand what you're saying about social, but how do you begin to address that issue? Because it is Haitians that are going to solve Haiti's problems, and like there are more Haitian doctors practicing in the States and Canada than in Haiti, you know?
Yeah, no, absolutely. I didn't respect the brain drain problem enough until just some years and years into watching people start with us and then move on to what they thought was next in their lives, whether it was more training or another job or just the stability of living in Europe or in the United States or Canada. On the medical side, 80% of graduating physicians are gone within 5 years. And nursing is about at the same pace, although a little slower because the quality of nursing schools isn't quite as high. There is you can keep people, but they have to be employed and they have to have jobs, and they have to have jobs that are worth working in. So at least our approach has been to create a system that functions and lets people do what they're trained to do. So there's nothing more, at least from like a medical point of view, there's nothing worse than being put in a spot without the tools to do what you know you could do to help someone. And so simply keeping a hospital stocked and ready and open and supplied is kind of like job one, just creating an environment where people want to work. No one, for example, around the question of who's employed, our doctors, we have about 150 doctors now that we're working hard to keep with us. None of them really live where we work, and so we house them and we bring them out from Port-au-Prince on rotations, and we try to make life sort of workable. The other thing that we've been doing increasingly and will continue with is trying to provide for the kind of advancement that these ambitious folks want. So higher degrees, ability to do leadership, ability to actually specialize within public health or within the field that they're in. So we've had a number of folks go out for training that have come back. And I was jumping ahead, I think it's many photos ahead, but one of the most exciting things for me personally, and I think for our group, is we've just founded a residency program that's in San Marc for Haitian doctors to train as family practitioners. And hopefully with another 3 years of good training within their own country and the potential to work afterward, I think many of those folks will stick around. We recruited 2 Haitian family practice docs to be the faculty, full-time faculty to that program. And so I think the same stuff that students want here, we have to help create in Haiti. So that's, working environment, decent paying job, but also ways to advance and to specialize and stay connected to the world. I don't know how much it was inflecting your students, but it can be isolating. It's a small country, it's pretty poor, getting through school is a real chore, and it's not a surprise that people do work to leave. And then unfortunately have trouble getting back or don't come back. Other thoughts? Let me ramble on a bit, and then we'll of course have time. So a way we've tried to capture this work, including home-based care, directly observed therapy, bringing medicines to people on a daily basis, trying to do it precisely, like with HIV, or like with TB, and almost more crucially with HIV, where the burden is quite high. You can't miss doses with HIV medicines and stay healthy, and so we've created a network to deliver on that. But also the work that, say, I do, or Paul does, or the accountants who work with us, or the logistics people, the supply chain people, working on this idea of accompaniment, of sticking with the problem, of taking on whatever's needed to solve a problem, of sticking with a goal and sticking with a partner through whatever it takes to finish, and not on our terms, but on the terms that are guided by local initiative and local needs. So it's one of the other great joys, besides being able to brag about Something Not Something Partners in Health and Haiti, is I don't do the work, and so that's easy. The other thing is I don't really make any decisions. I show up and I work, and I'm told what to do by my colleagues, and we muddle it through together. I've been very happy, just personally, to not be in a position of really much or any authority. I go and I work, and the priorities are set jointly. Really, everything is done as a collaboration, and to me, that's what makes this sustainable. The kind of depth and support and kind of novelty or potential that comes with partnership and continuing to grow is really what makes it possible. Things like raising money and providing technology and building buildings, that's all got to happen as well, but it's through these partnerships and through accompaniment, through sticking with the problem. And so, at least for us, this has become a kind of key word, and whenever we're not quite sure what to do, we sort of, for ourselves, evoke this, okay, what would be the next right thing to learn more about what's going on, to think about what the next steps are. And I had this conversation today around a child we're trying to get from Guatemala, from getting heart surgery back to Haiti, where she lives and needs to be. We couldn't figure out how to do anything. We couldn't figure out how to arrange for care and translation, and so the solution was to get one of our bilingual Haitian colleagues to Guatemala to accompany this girl for the next couple of weeks while she recovers. And it's going to solve a world of problems, and not like one size fits all, but it's a way of working that's been really exciting and expanding, and I think worth just putting in your vocabulary if you remember. In terms of delivering care, it comes down to this. It comes down to people on the ground. I don't like military metaphors, but boots on the ground and delivering in people's homes, creating a safety net, creating a spread that just didn't exist before. So where roads and telecommunications and distance are a challenge, getting people to go out day after day to provide medicines, check in on their neighbors, provide that feedback. That's our structure. The medical stuff works. But it works because of these things, the social context working in multiple directions, but then also delivering on the ground. So currently, Partners in Health is in these places, and actually a few more with affiliate projects. One of the most exciting pieces for me is a small group in Liberia that's taking the Partners in Health model to help take over and administer a district-level hospital, providing community health worker care, using this public-private partnership model, which I may not harp on much, but it's a big part of what we're doing in Haiti. Anyway, Liberia is on the map as of the last year, and so it's an expanding network, including the United States. Let me end, or at least talk a little bit about the earthquake and sort of what's going on.